First, I would like to call Dr. UMESH. Yeah. He will talk on blurring stopped, worrying continues following refractive surgery.
Good morning, everybody, and welcome to AIOS2025. Thank you.
1 minute. Slide.
Thank you, Dr. Mallikarjun, for carrying out this instruction course and quite a few topics of interest, especially for practice management. Most of us see these problems day in and day out, and I think it is prudent enough on us to go ahead and find what is the pathology, etiology, pathology, and also management options available. Refractive surgery, yes, I'm sure most of us who are doing refractive surgery see this one. The refractive surgery is the most performed surgery in this world right now, and it is very satisfying both for the patient and the doctor, especially the outcomes. But even though the anatomical success is very high, we see quite a few number of patients complaining of either blurring or some other complaint, especially asthenopic or dryness complaints. And that is when they come to the OP, we all feel that why you have got 6/6 vision, you are reading 6/6, why are you still complaining? So that is one thing that most of us feel as surgeons, but we need to take their complaints and also understand what is the possible causes. What are the possible non-refractive causes of refractive surgeries? Mainly dry eye, of course glare and halos. There are temporary visual disturbances, basically binocular vision anomalies, non-strabismic binocular vision anomalies. So what happens actually when the refractive surgery is done is there is the nerve plexus is cut, corneal nerve plexus is cut, which causes neuropathic keratopathy, dry eye, and most of them complain of these symptoms, irritation. It could be combination or it could be one of these: irritation, burning, foreign body sensation, and tearing. And this tearing is actually very problematic. We feel that they are dry eye and they are complaining of tearing. So that is where we have to be careful in assessing, along with fluctuations in vision. The fluctuation vision, very classical. The patient is reading 6/6, you get a 0 on AR and your retinoscopy, but still they're complaining of fluctuations in the vision. The more severe, very rarely you see hyposthesia, that is delay in corneal epithelializations, sometimes very rarely neurotropic ulcers also. So I think it is, we must understand what is the anatomy of the basal plexus, that is the stromal vessels. They enter to the stroma, mid-stroma, and lose their myelin after entering 1 millimeters, and then go up perpendicularly, pierce the Bowman's, and becomes the subbasal plexus. And these three are very important: the stromal, the subbasal, and the subbowman's plexus, nerve plexus. And these subbasal plexus end up as nerve terminals, which perceive the different mechanical or chemical perceptions. So what happens post-refractive surgery? The LASIK, what it does is it transects the subbasal fibers, and the stromal ablation damages the stromal fibers. So both in LASIK, both the subbasal fibers nerves is gone, and also the stromal ablation causes the stromal nerves also is cut. In PRK and SMILE, theoretically, only the stromal nerve is affected because the subbasal nerve plexus is preserved. And that is what you see at the confocal microscopy here. In post-operative 1 year, the LASIK recovery is late, whereas the PRK and SMILE recover much faster, and hence theoretically they give lesser dry eye symptoms. The etiology, of course, is post-operative inflammatory response. The production of MM6, interleukin, nerve growth factors, all these things. Damage to conjunctival goblet cells, especially surprisingly, the femtosuction causes more damage than the mechanical suction. And the change in corneal curvature, obviously, flattening causes instability of the tear milim, blink reflex, and the ocular surface, lacrimal gland, neuronal reflex is lost. The incidence ranges from 36 to 75%, this dry eye. The PROWL study, that is the patient reported outcome study, there is a PROWL 1, PROWL 2. PROWL 1 was done on US Navy people and PROWL 2 was done for the normal citizens. It showed that 1/3 patients, approximately 1/3 of all post-LASIK did suffer from dry eye, and of which 4 of them had very severe symptoms. I believe that this is the 4% whom all of us have to cater to. And usually the symptoms peak during the first week and recovers in 6 to 12 months time, depending on the various factors we'll discuss later. And approximately, this is a very big range, 8 to 48 different studies are showing that it will be affected up to 6 months post-LASIK. However, in post-PRK, the 37 patients complained dry eye symptoms after PRK. The risk factors for the dry eye are, preoperative risk factors are the preoperative dry eye. That is why assessing dry eye is very important. Higher the power, higher the chance of dry eye, obviously, because more ablation depth, more stromal cut, and you will get more chances of dry eye. Contact lens users, yes, because of the ocular surface inflammation, long-term inflammation. Females, older age are more prone. Compared to Caucasians and Asians, Asians do have a more propensity for dry eye. These are the risk factors. Surgery-related factors, surgical technique, we saw PRK smile, theoretically they should get lesser compared to femto or mechanical LASIK. Stromal ablation, the 6 mm zone, more the chances. Hyperopic ablation, because the periphery, the plexus are more. So hyperopic ablation causes more dryness than flap diameter. Yes, the lesser the diameter, the more diameter you get. Thickness of the flap. Previously, we all used to do 130, 140. Now most of us are doing 90, 100. So that way, to some extent, it has come down. But otherwise, that definitely matters. And the hinge position. The bigger the hinge position, the more chance of dryness. The smaller hinge position. Superior versus nasal. Nasal, possibly the fact is the long ciliary plexus at the nasal are preserved. So there they say that the dryness is much lesser. Many studies are there. Many studies right from 2000 up to 2022, from early 2000, most of them, I am just showing all the studies just to show that consistently right from 2000, irrespective of the changes in the refractive surgeries, we are seeing that somewhere around 27 to 30, 1/3, 30 to 40% is the dryness, irrespective whether they had pre-operative, post-operative, and most of them return to normal after 6 months, within 6 months. Very few went on to have these symptoms for up to 4 to 6 months. This is 27 study, 27.5%. The 2015 study, they returned to normal for up to 3 to 6 months. This 2000 study, 20%. So most of them are well within the 1/3 what was earlier described. And this is 2001 study showed 41%, 14%. So somewhere 20 to 40% is the average, and if you do your homework well, maybe you could reduce that. The management, yes, tear supplements, you have a gamut of tear supplements available in the market, and most of them are doing well. The polyethylene glycol and polyvinyl alcohol, PVC, and PVA and PEG, they said it was better, but when compared with hyaluronic acid, they said it was similar efficacy. Most of them are all more or less the same, but CMC with hyaluronic acid did a better job. So people who complain more, maybe this combination could do better. So CMC with high A was better than CMC alone. Cyclosporine as a prophylactic did not show any effect, but that was way back in 2013, and they used 0.05%. Now we have the 0.09% Sequa drops. We don't know what is the newer, whether prophylactic will help or not, but we are using in some cases. But definitely those who had preoperative dry eye, cyclosporine did help in the long term. Since I don't have any this one on the experience on this, but they say that it improves mucin and also dry eye, and that is the diaquophosphol tetrasodium. Autologous serum in very severe dry eye, both plasma rich platelets and autologous serum did help, that you can keep in mind. And punctal plugs, yes, it does help. That all these things you should keep in mind in patients. There will be 4 to 5% of patients who will keep complaining to you. You do this, most of them will be comfortable. One more. Shall I continue?
I can continue.
Okay. It's not moving.
One more minute.
Okay. The other things is glare and halos. Glare and halos are yes, significant, again related to dry eye, and most of them subside within the first 3 months. Very rare. And for those who are significantly, we have used brimalol, and that definitely gives some help. Rainbow glare, classically in post-femto, that was because of the on the surface, back surface of that, and that also reduced. Especially this was very visible in the early stage where the higher energy and low hertz were used. Now the hertz resistance has increased, is feeling better. This one study which did was persistent post-operative pain. This also they did in after refractive surgery, and surprisingly this was there, and this percentage 11% was the same that occurred even in general surgery patients like hernia and hysterectomy patients. So mostly somewhere the persistent pain is related to these things. And non-strabismus binocular vision elements, nowadays we are seeing a lot of asthenopic symptoms because most of them are having a lot of screen time. So now as part of it we are doing binocular therapy for patients complaining post-operatively, and we are getting very good results. This is a couple of studies done by All India where they did find significant changes in the initial, but especially in the AC by A ratio, stereo acuity, and all these things. But most of them came back to normal within 6 months, even stereo acuity also. I think to conclude, laser refractive surgery is very safe, very effective, very high satisfaction indexes. Most effects are transient. With good understanding of symptoms and adequate care, we can give them, and most important here is reassurance, and that is one which takes us to manage these patients. Thank you.